September meeting of the Kansas COVID Vaccine Equity Task Force. Always nice to see all of you. In case there's someone I don't know, my name is Jimena Garcia, and I'm Governor Kelly's.
Are you going out to pick up?
I have to fill the van up with gas.
Okay.
So
Hi, we need somebody to mute, please. Okay. Sorry, got my. So I'm Governor Kelly's Senior Advisor for COVID Vaccine Equity. And to start out with, we have a few housekeeping items to share. So COVET operates in compliance with the Kansas Open Meetings Act. This meeting is being recorded and broadcast live for public viewing on Governor Kelly's YouTube channel, which we provided public notice of prior to today's meeting. We ask that you mute yourselves when not speaking to prevent audio interference. And also, before you speak, please state your name and title. And so we're going to start with a roll call. Please say here. When I call your name, Annette Graham, Martha Gabehart.
I'm here.
Stacy Knoll, David Jordan, Michelle Ponce, Kelly Summers,
Here.
Johnella Holmes. I saw Johnella Holmes. I know she's here. John Carney, Rachel Monger, Sarah Landry, Sarah Obermeyer, Jean Luger, Tara Nolan.
Here.
Lashika Williams,
Here.
Charla Smith,
Here.
Mariana Ramirez,
Here.
Nicole Garner,
Here.
Virgil Watson, Edith Gaines,
Here.
Christina Simmons, Mang Sana,
I'm here.
Tara Remington Brown, Erica Andrade,
Here.
Connie Satzler,
Here.
Elaine Johannes,
Here.
Roderick Crawford, Ed O'Malley, Dashinika Poindexter, and Shannon Olson. Okay, great. And for people that join later, we'll have you put your name in the chat. Okay, so I just wanted to run through the agenda for today. So I'm going to start out with the usual update on the state of vaccination in Kansas. Next, we'll move to our main presentations and discussions, which center on Native American vaccination in Kansas. We will hear from Rear Admiral Travis Watts, Director of the Oklahoma City Area IHS, and also Tara Nolan, Community Health Manager at Hunter Health in Wichita. Thank you both for being here. After that, we will hear a brief report from Martha Gabehart, the Executive Director of the Kansas Commission on Disability Concerns. Finally, Vicki Collins-Akers will lead us through a summary regarding topics and direction for COVID based on the work we did last meeting. And in closing, I'm going to share some details about a new grant available for local groups doing vaccine equity work. So before jumping into the meeting, we have two new members. I was wondering if could introduce themselves to the group. First is John Ella Holmes.
Good afternoon, everyone. I bring you greetings from outside historic Nicodemus, Kansas. I am the Executive Director of the Kansas.
Can't hear her very well.
Uh-oh.
It sounds like you're kind of far from the mic.
Okay, I have my volume up. Is that better?
That's better. That's better.
Okay. I bring you greetings from historic Nicodemus, Kansas. I am the Executive Director. I am Dr. John L. Holmes of the Kansas Black Farmers Association. We received a grant to do COVID equity awareness, and we're just working with any and everyone that will work with us to make sure that our farmers, those in rural areas, and those in predominantly minority ethnic areas are served and can be served. That's what we're doing.
That's amazing. Thank you so much. And thanks for being here. Charlotte Smith, are you on?
Yes, I'm here. Greetings, everyone. I'm Charlotte Smith. I'm an assistant professor in the Department of Population Health and Obstetrics and Gynecology at the University of Kansas Medical Center in Kansas City. And my work has been focused on maternal and health disparities. And I'm the founder of the Kansas Birth Equity Network and really focusing on COVID disparities in pregnant women and increasing awareness and vaccination among pregnant women. Thank you.
Thank you so much. And thanks for being here. Okay, so I think we can go to the next slide. And I'm going to start my my update. Next slide, please. Okay, so this slide shows COVID case numbers since July of 2020. And you can see the blue line represents cases in Kansas, and the other lines are rates in the surrounding states. And what you can see is that we had a big peak in cases at the end of last year and into the beginning of 2021. But as the vaccine became available, the cases dropped and reached a low in the spring. Then in early summer, we had the appearance of the Delta variant. So what starts to happen then is that cases go up dramatically to levels that we haven't seen since January of this year. Next slide, please. So here you can see kind of a snapshot of the status of COVID-19 in Kansas from left to right. We'll start with the daily cases of COVID, which have continued to increase to new highs. The next chart shows us deaths in Kansas, and we've hit a new high death rate that we have not seen since February. Next box shows us testing. This is so we're seeing increasing testing, which is good. And finally, vaccinations, which you see continue to slump. Next slide, please. So here we are, the status of vaccination in the state as of 9/16. So the adult population that's fully vaccinated is at 61%, and the eligible population of 12 plus that's fully vaccinated is 59%. I think today's data shows that now we have actually a new milestone. 70% of the eligible population in Kansas is vaccinated. So that's a testament to a lot of work that a lot of groups are doing. And then when we look at the total population, we have almost half of the total population of Kansas fully vaccinated. Next slide, please. Next slide. I want to tee up the conversation for today's presenters with a couple of data slides that I have focusing on Native American vaccination in Kansas. So this slide, next slide. In this slide, you can see the rate of Native Americans vaccinated in Kansas, broken down by age. So you can see that Native Americans over age 50 were vaccinated at a very fast rate, much faster than the rate in Kansas as a whole. So actually 2/3 of the doses of vaccine had already been given to Native Americans before Kansas even moved into phase 5. So that's really a testament to the community and to the great way that the vaccine was rolled out. The blue line at the bottom is the rate of vaccination in kids age 5 to 17. What we've seen is the vaccination rate in kids is growing much more slowly so far, but the way this data is presented, it's kids ages 5 to 17, which I don't think is a fair assessment of the data because only kids 12 and over are eligible now, but it is kind of a trend that we're seeing that the child vaccination rate is much slower than adults. Next slide, please. So here we see that the Native American vaccination rate compared to the it's a summary of the Native American vaccination rate compared to Kansas and the US population. This data is a little bit old. It's from August, but it's the most recent we could get. And you can see that Kansas American Indian vaccination rate is the same as the vaccination rate in Kansas overall. in adults, the Native American vaccination rate is higher than it is in Kansas overall, and it is similar to the vaccination rate that we see in the United States. In kids under 18, the vaccination rate of American Indians in Kansas is a bit lower than in the state, and also a bit lower than in national rates. So that's the end of my update. And at this point, I would like to pass it over to our amazing facilitator, Vicki Collins-Akers, to introduce our speakers and manage the next portion of the meeting.
All right, thank you, Dr. Garcia. We are very excited to welcome two speakers who will talk about their advancing vaccination efforts. I'm going to take just a minute to read a very brief synopsis of each of their bios, but they are two people who have quite the illustrious career and path behind them. So the full bios are in the back of the slide deck, and I hope that you'll take some time to learn more. We're pleased to welcome Rear Admiral Travis Watts as our first speaker. Rear Admiral Watts is a member of the Choctaw Nation, is the director of the Oklahoma City Area Indian Health Services. The IHS, an agency within the Department of Health and Human Services, is the principal federal healthcare advocate and provider of healthcare services for American Indians and Alaska Natives. We also are pleased to welcome Tara Nolan as a speaker who will follow Rear Admiral Watts. Tara is the community health manager for Hunter Health in Wichita, Kansas, and she's responsible for providing strategic oversight of Hunter Health's COVID-19 efforts and community outreach and engagement strategies for key populations, as well as strengthening relationships with community partners. We will have time to listen to both speakers, and then they've both agreed to sit for questions and answers. So with that, I will invite Rear Admiral Watts to begin your talk.
Thank you, ma'am. I want to make sure you had access to my slides and that you had control of them. Thank you very much. Okay, next slide. I appreciate the opportunity to come and speak today. I'll try to keep my comments brief, just making sure that we're comfortable. I appreciate the state of Kansas allowing me to be on the call today. Again, the Indian Health Service is one of the main agencies responsible for providing federal health services to American Indians and Alaska Natives. And the Oklahoma City area is one of the 12 areas of the Indian Health Service. And the Oklahoma City area serves states of Oklahoma, Kansas, and portions of Texas. And the Oklahoma City area is home to about 43 federally recognized tribes and 5 tribal organizations that run urban programs. And the program that you're going to hear from today, the Wichita program, is one of those programs. The IHS provides federal funding to tribal, urban, and then federally ran facilities. And the area provides services to about 388,000 American Indian and Alaska Nation citizens. Those are users of our programs. There are many more American Indians in Kansas, Oklahoma, and Texas, but we have about 400,000 that actually utilize our health systems throughout those facilities. So when you look at the Oklahoma City area, they call it Oklahoma City area because we name it after the town or the city that the area office is located in. But again, we serve Oklahoma, Kansas, and portions of Texas. When you look at Kansas specifically, there are 4 federally recognized tribes and 2 urban Indian organizations, either in Wichita and Kansas City, and then 1 federal program up in the state of Kansas in Lawrence. And they're listed there for you below. Basically, we have 1 federal ran facility, 3 tribal ran facilities, and 2 urban programs in the state of Kansas. And there's about, of those 388,000 citizens, we roughly have around 6,500 users there in the state of Kansas. So you see the majority of the users are in Oklahoma, but we do have a federal presence there in Kansas with the 4 tribes that we serve and the Haskell Indian Nation School there in Lawrence and the 2 urban programs. Next slide. So, you know, at the end of the day, I just wanted to kind of speak to you a little bit that whenever the pandemic hit it first, the federal government allowed the tribes to determine whether they wanted to receive vaccine from the Indian Health Service or the state that they were in. The Indian Health Service was allowed to be a jurisdiction for vaccine distribution, just like the states were. So at the very beginning, we worked closely with our tribal nations to help them determine or to let them determine who they wanted to receive the vaccine from. I want to say that the state of Kansas, that your vaccination program has been incredible to partner and work with us as well. At the very beginning, we had several calls and conversations about the tribes, just making sure that each tribe had the information they needed to determine who they wanted to go with. The Oklahoma City area, since the pandemic occurred, the tribes and federal and urban programs have provided over 672,000 tests. They provided over 413,000 COVID-19 vaccinations, and that's about 25% of all the vaccinations in the Indian Health Service nationwide. So our jurisdiction, out of our jurisdiction, the tribes in Oklahoma, Kansas, and Texas have done 20 total vaccinations. They've done just an incredible job in their vaccination process. Within the entire area, all three of those states, we feel that we've fully vaccinated about 189,000 American Indians and Alaska Natives, about 56% of what we call our user population. Here in the state of Kansas, we've done about 26,797 doses and about 11,000 vaccinated in the area. And I've broken down a little bit further in different races and ethnicities if you kind of wanted to know, just to give you an idea that not only has the tribal and urban and federal programs in the Indian Health Service vaccinated American Indians, but we also opened up our vaccination process to all comers if they wanted to come and get vaccines within our programs. And those are kind of some of the statistics there. Asking what approaches that we use to engage and support and reaching underserved populations, I just want to be very, very upfront and frank with the number one thing. And we felt it was the relationships and partnerships that we had already built with the tribes. I think that was the biggest success that we had. We utilized our same communication lines, used our same facilities and distribution processes and all the things that we have had built over the years. We just kind of put those on steroids, increased communication, increased our communication lines, increased our distribution processes to move the vaccine, the testing, and all the supplies, PPEs that was needed for our underserved population. So those long established and trusted partnerships, I feel like, are really what has allowed us to be successful in the area of vaccination processes and the treatment during the pandemic. Also, when we looked at the partnerships, not only has it been with the tribes, but the partnerships with the state and FEMA and CDC and ASPR, local partnerships. It's taken everybody to work during the pandemic. And all of these groups, when we have lacked a resource or lacked an ability to support a function with the tribes, they have stepped in and done an amazing job as well. So, the IHS appreciates those partnerships as we've moved on. And when you look at the tribes, they have done an incredible job with community engagement, allowed the use of their ambulance services, tribal facilities, law enforcement. The pandemic has required our health system to really expand what its capabilities and scope has been. And the tribes have stepped in and provided services where the Indian Health Service didn't have those services. Next slide. So, the resources that we use, of course, we had allocated funding. There are 6 different COVID supplements that were provided to the Indian Health Service that we moved to the tribal programs. And of course, a variety of different state, federal, and local agencies have also provided funding and support. And of course, we use our annual funding that was originally arranged for other activities. We've pushed it over into COVID and realigned our program to focus on the pandemic as it's needed. And again, our partner resources, and then our ability to bill for services. We've put third-party collections into the pandemic, and then our volunteers and communities have provided a lot of volunteer service during the time. So it's taken an entire village to make this pandemic, to control where we're at today with the pandemic. And we've used all sources. No resources or funding lines were excluded when it came to the pandemic. Next slide, ma'am. So our lessons learned, I don't think you can ever have too strong of a partnership, too strong of a communication line. We leaned on those established relationships, but I think they could be even stronger. And they've actually strengthened during the pandemic. If there's one pro that come out of this on our relationship line, is that we have stronger relationships now, I think, with emergency coordinators, with ASPR, with FEMA, with the CDC. They know more about Indian country and more about our underserved populations probably than they've ever done because they've done more work in that area. So I think the lessons is learned is that we have to continue to strengthen and have these partnerships year round to make sure that they're aware of these underserved populations and our American Indian communities. We also in the agency have realized that we really lack an emergency management section that is robust enough and flexible enough to handle these type of pandemics, emergencies. And so instead of putting the resources toward them when it's happening, we understand that we need to have some chronicity and some sustainability when it comes to emergency management. Also, our data infrastructure, the connectivity needs to be stronger between the states and the feds and all the groups that are working during the pandemic. Have known this before, but our health system still remains too fragmented when it comes to data infrastructure. And then, as we talked about before, some sustainability. Some of our partners kind of come and go, and we do as well within the Indian Health Service, and we need to have a little bit more of a sustainable process when it comes to emergency management as we move forward. Next slide, ma'am. So, how can we do more of this? I think just to kind of feed on the sustainability piece, at the end of the day, really, we need to focus on not just the current pandemic, but also begin to where we're going to go with our testing, our vaccinations, emergency response, working with our partnering and our roles. That really our focus needs to be on how are we going to sustain our process, because this is really here for a while. We keep thinking it's an acute conversation, but the reality is that we feel that whether it is the next round of third doses or the conversation about boosters continues or, just the testing, society has decided that it's moving forward. And we have within our tribal programs and within our communities, the need for community engagement is there. And we don't need to be thinking, well, let's just social distance and mask and stay away. We have to find a way that we incorporate social distancing and masking, but also in a manner that allows our communities to come back together. We feel that we understand that our communities are telling us it's time. They don't want to have funerals with nobody there. They don't want to have dances or ceremonies delayed anymore. They want to live life. And it's important for us to figure out a way, whether it's through testing or vaccinations or whatever we need to do, that we need to sustain this process as we go forward, to get our communities back to where they need to be. Next slide, ma'am. Thank you very much for your time. That's the end of my presentation. I'll be glad to take any questions that you may need. I appreciate you giving me a little time today on your conversation. Thank you.
Thank you, Rear Admiral. We appreciate it. I hope folks will use the chat box. We will do questions after the next presentation. So at this time, I'd like to invite Tara to begin her presentation.
Thank you very much, Vicki. Yes, I'm Tara Nolan, Community Health Manager with Hunter Health Clinic. If you don't know much about us, as Rear Admiral Watts was saying, we are an urban Indian health center in Wichita, Kansas. We're also a federally qualified health center. So we do serve all underserved populations. We can serve everyone, but we do focus on American Indians and Alaska Natives specifically because of our funding that we get through IHS. And we do have the Native American program in which they can receive almost free healthcare for most of the services that we provide. Next slide, please. So just to kind of show exactly why one of our main focuses, other than the fact that, we're an urban Indian health center, why we decided to focus specifically on American Indians during the pandemic. Data came out pretty early on showing that Native Americans were 3 to 5 times more likely to be diagnosed with COVID and twice as likely to die from COVID. So there was definitely some disparities apparent early on. And, the reasons why, it's kind of why we're all in this group, that we're here. There's definitely some health inequities that have been, put on that group of people historically and that continue today. And a lot of socioeconomic factors, availability of resources and, even knowledge of our program as being an urban Indian center. A lot of people don't know what what we have to offer for American Indians in Wichita and in Kansas. So a lot of that has, lends to the health of the population. Next slide, please. So during the pandemic, we had an unusual opportunity to partner with the Washington State University as part of the RADx program. You might have heard about it. It's a lot of the grant funding was done on studying COVID testing, and there was some of this funding was done here in the state of Kansas. They were able to, in the middle of their IRB process, actually update it to include vaccination questions when they were surveying patients about their attitudes and beliefs around COVID in general. So we got a really interesting insight about what our patients were thinking about the pandemic in the middle of the pandemic, which kind of helped us develop some strategies on how we were going to approach the subject. So in general, there's a lot of wide variety on how people feel about COVID, but we did see that there was, in the people that responded to the survey, there was actually, a moderate to extreme concern about getting sick with COVID. So we did know there was a portion of our population who really did, understand the severity and nature of the illness and their risk at getting the disease. With testing, there weren't significant barriers to access. They did understand that we provided testing. There wasn't concerns with coming to the clinic to actually get tested. There were certain patients who responded who didn't think the benefit of testing was worth the effort, either whether coming to the clinic to get it or, the dreaded nose pain of the Q-tip up the nose. And then, they did say rapid results. So rapid testing, which we all, if, you're planning right now, we know that there's a shortage of rapid tests and convenient locations like drive-through testing and things like that we're trying to ramp back up. So all of those things kind of help us plan around what we can do to best serve this patient population. Next slide, please. So we actually got this information before vaccines were available even. And so this was really great. So we could kind of plan and see what people were saying about vaccines. So there were a lot of people who were hesitant about vaccines. And we see this in, a lot of marginalized populations anyway. So the top reasons were, safety, risks from the vaccine. A lot of people didn't understand, how the process went about for the testing of the vaccine itself, not trusting the public health information, not understanding, the public health process of how we present the information as we have it, not understanding the safety concerns and not trusting the drug companies, and then being worried of being used as guinea pigs, as we know has been historically, the case in some populations. And then not knowing that the vaccine was going to be provided for free. So thinking that it was going to be high cost because it would be obviously in high demand. But then we got to see what people were saying, why they would get it. So, keeping their family safe, keeping community safe, keeping themselves safe, and then, worried about chronic health problems. So we could use those as actual reasons to discuss with patients about why they should get the vaccine. Next slide, please. So then when we started rolling out our vaccines, and we actually, as was mentioned before, we actually did get our vaccines from Indian Health Services. So we were able to roll them out in a different path than the state because we were allowed to choose kind of how we wanted to phase out our vaccines. And we did start with Native Americans. We were going to use what the state was using of, 75 and up or 65 and up. And we started listening to patients and, kind of running that by them. And elders is a huge, thing. Like it's a respectful thing in the Native American community. And elders are considered that at age 55 and up. So we decided we should start with all elders and not limit it to a section of elders. And so we started rolling out with 55 and up current patients so that we could definitely limit, we did have a limited supply in the very beginning. And then, and they shut our phone system down. That's how many people called us to try to get vaccinated that very first week. So that was amazing to see how many people were actually interested. And then we started rolling it out. We increased that to ages 40 and up, and then started opening it to, other parts of our population at ages 55 and up. And then finally, we're able to increase that to ages 18 and up. So we were able to hit some of those areas in the Native American population much quicker than across the rest of the state. So that slide that Jimena showed in the very beginning about the 55 to 64 age group, I thought that was really interesting how they were the highest vaccinated rate, because that's exactly where we started. And so I think maybe that was the case across the state. Next slide, please. I'm sorry. So another thing we did was we did targeted outreach. We took vaccines to people. We have a really good working relationship with through a coalition, a local coalition called the Native American Community Resource Coalition, and it's got 10 to 15 different group memberships, including major tribal organizations here locally, and then just other resources that are widely used among our local American Indian population. And we use them as kind of the vessel to get information out and kind of solicit, our audience. We partnered with the Mid-America All-Indian Museum here locally to host this event and opened it up to Native Americans 18 and up and their household members. Their household members didn't have to be Native American. Somebody presenting that day had to be. And we had a line almost across the street. It was just really, it was a wonderful event. You can see on the left-hand side of the screen, we had several vaccine stations open. We had our staff and volunteers out in the parking lot handing out clipboards so people could get their paperwork filled out. And then on the right side of the screen was something that we did just recently. We were at the Back to School Powwow event for the Wichita Public Schools Native American Education Program, providing vaccines to people ages 12 and up. And so we were able to provide school-age children vaccines. So that was a really unique experience to take staff to and get to be in front of, families and get to talk to them and see how excited people were to hear that the 5 to 11 vaccines are, right around the corner as well, hopefully. And you'll see in the middle there is our COVID team lead nurse, Lashika Williams. She's on the call today too. And our nursing staff has been absolutely amazing with these rollouts. And, I'm the planner. I come up with the ideas and I kind of work behind the scenes to make sure we have a place to go and an idea of where we should go. But it's really the hard work of the actual vaccination teams that kind of get this accomplished and get the shots in the arm. So we definitely couldn't do that without the hard work of those teams. So we appreciate that. Next slide, please. And then finally, I just wanted to show by the numbers here, and you can see our numbers kind of match what was shown earlier, that our biggest populations vaccinated is that, 65 to 50, the 55 to 65 and up group. We have a low amount of that 12 to 17, but we, as school started, we have seen more of that age group across the board of all race and ethnicity, filing in. So our vaccine numbers have picked up daily and weekly. And so that's really good to see again, because they had obviously dropped off everywhere there for a while. But we're getting ready to go to another outreach event here in a couple of weeks for the Trail of Tears Memorial event, again at the Indian Museum, where we'll see all ages again, Native American individuals, and take hopefully flu vaccines along with COVID vaccines and get a lot more shots in arms. So that's all I have. The last slide is my contact information. So.
Great. Thank you very much, Tara. We really appreciate it. At this time, we'd very much welcome questions. We have about 6 minutes remaining for our guests and would love to hear your questions for them. It looks like Kelly has one.
I really appreciate your presentation, both of your presentations. They were so good. I appreciate too that you brought up pre-existing conditions, because I think that's something that we need to start thinking about more when we give vaccinations also. With American Indian population at much higher risk or higher levels of type 2 diabetes. Have there been any programs that you've been able to do along with vaccinations to get people more healthy, or are there any issues with resources to do so? Because I'm sorry, and I'm Kelly Summers with Kansas State Nurses Association.
Was that directed to me?
Either one of you. I'm just curious because we've been working on developing some programs, and so I've always would like to hear more.
I'll just comment. We are a patient-centered medical home, so we do have full integrated care model here. So if they're seeing a provider, they have behavioral health care as well, and so they do counsel on all of those types of things, whether it be substance abuse, diabetes prevention, hypertension issues. So they refer to programs all the time. We do have people who are trained in the diabetes prevention programs here. We don't have any current classes, just COVID kind of put a stop to that, but we do have plans to reinvigorate those classes in the future.
Thank you, Tara. I couldn't, Rear Admiral, did you want to add?
Just, prevention conversations are always very interesting conversations, and that we talk about prevention, but then when the rubber hits the road with funding, lots of times it gets moved over to acute care, because the patient in front of you, unfortunately, sometimes it is where the attention goes. But in saying that, it's no excuse for preventive. And I think the Indian Health Service has really seen that it's important that we provide prevention processes. I think one of the ones that's been most successful has been in the areas of diabetes. We have the Special Prevention Diabetes Project for Indians, or SDPI. It is a process that focuses directly on prevention of diabetes within the population. There's been some pretty nice data put out by this program, but it's a program that specifically focuses on healthy lifestyles, socioeconomic barriers, and so on. And I think there needs to be much more of that within our program, because that's really where this gets to. We talk about vaccines and testing and the work that we're doing now, and it definitely saves lives. But we know that if we could continue to work on those socioeconomic barriers and the food deserts and the health education and the access to care and all the things that wrap into the obesity and exercise and all that work, if that's done on the front end, that when pandemics hit this country, we're in a much better place. So definitely the agency puts its prevention access efforts, puts money toward it, puts grant processes there, and we continue to focus because we know that work saves us in the end of doing less work whenever it becomes more acute. Thank you.
And I appreciate you addressing that because, in the hospitals right now, obviously I'm a nurses association, but our concern is that we're seeing the sickest of the sick right now too. And so we want to make sure as a nursing association that we're putting our best foot forward to get people more healthy. And so always feel free to reach out to me with any ideas or something that I should be doing as we start to create more of these programs. I would love to get more feedback or ideas.
Thanks, Kelly. We have other questions that I'm going to tee up. John, you had a question, I believe.
Yes, thank you. Great presentations, both of you. Really appreciate it. My question is related to therapeutics that may be necessary to address issues for those who are high risk who have not received the vaccine. We've had some experience in the Kansas City area about limited access to monoclonal antibody treatments, and just wondered if you were working or having any experience of that yourself for those that may either be a high risk and vaccinated or unvaccinated in terms of therapeutics.
I don't actually have an answer to that. Lashika, I don't know if you have any information on that or not. I know our chief medical officer has gotten some information on that. I don't believe that we are doing that here as of yet, but I really honestly, I'm not positive on that.
Yeah, the Indian Health Service has access to monoclonal antibodies. We do have them and do distribute them to the sites in the area that can infuse them. I think the bigger issue right now, even though we have had a reduction in the number of availability of monoclonal antibodies, that's nationally. ASPR and FEMA and the group has continued to work with us to provide them. So the drug is available. I think the bigger issue with us has been access to infusion services, whether that's trained nurses or
I'm not sure. I think, did you have more to add? I think the sound cut out. Sorry, sir.
Sorry about that. Just quickly, I think that the access to the monoclonal antibodies is available through the Indian Health Service. So the tribal programs can have access to the drug. Where we have had issues has been really more with the availability of an infusion service, whether that is trained staff or infusion clinics or chairs, availability of locations to infuse the service, because many of the rural facilities, the smaller facilities, do not do infusion services. So I think access to manpower has been really more of a concern than actually access to the antibody itself. Thank you.
Great, thank you. I see another question from John Ella. Uh-oh, I think we're having a hard.
Are you able to hear me?
We can now.
Okay, great. We are doing a special program out here in Nicodemus because we mainly concentrate on developing programming. And so October the 2nd is our Pioneer Days. And we have partnered with the Potawatomi and Osage tribal nations, and they will be out here. So with these amazing numbers, how can we celebrate those numbers and encourage? And also, what age groups should we concentrate on while they're out here that we might could provide this information to? That, which brings me to another question. Can you send me some of your information, your brochures or flyers, and I can provide you with my address? And then lastly, can I use the information as a video for my staff training?
Did you everybody hear that? I think I caught all 4 questions. We had a little bit of a hard time, but Jonella raised up, how do we celebrate the accomplishments that you all have identified? Given the age distribution that you both shared about, are there ages that should be the priority? And then I think she had some questions about the extent to which she could use some of the materials that you shared. And hopefully I got those, Jonella. If you have others, if you would put them in the chat, that would be great.
Yeah, we've actually, I'm actually in the process of prioritizing some kind of next steps for, I just completed our community needs assessment for just future planning, not just COVID planning, but, you know, we always want to reach younger populations in general, but we are ramping up for that 5 to 11 age group that we would like to see, you know, a major increase, because we know that there's a lot of risk going on in the school systems right now, you know, with outbreaks and kids. So that's definitely, you know, an area where we need to focus in. You know, when I was looking through the data, the 18 to 24-year-old group and the 25 to 34-year-old group were the least likely to follow up with their second dose and complete that vaccination round. So we can always do more education on the necessity of that with them. And as far as sharing that, if you send these slides out, please feel free. It's you know, it's available information. So
great.
You can definitely contact me for further information, Jonella, if you'd like to do that as well.
the Indian Health Services slides are fine to be sent out as well. I mean, they were very, very minimal. We're always glad to provide more or any kind of guidance or information that anybody would like, but the slides today were fine. And as far as celebrating our successes, you know, the agency, the area did do something this year. We have an annual award ceremony that we put on every year and provide awards to our tribal, urban, and federal programs for all the hard work that our employees do. And this year we actually just did a COVID awards where we focused on the efforts holistically of all of our programs. They've done an incredible job, great work, and they're tired and we're fatigued. Our health system is, but they continue to come to work every day. So we've focused our awards process this year internally on COVID-19 accomplishments. So that's where I'm at today. Actually, I'm sitting in the urban program in Tulsa, and we handed out their COVID award to their staff today to recognize them. Thank you.
That's really great. Really important to celebrate accomplishments. I think we'll have our last question from Mariana Ramirez.
Thank you. Thank you both for a wonderful presentation and congratulations on the great work you're doing. I was wondering if you could share a little bit on the communications and what were the main myths, misinformation, disinformation that you were hearing in your population, and how did you address that?
Yeah, so we used a lot of social media. We used our website a lot for communications. And one thing I forgot to mention is we had actually we have a YouTube channel that we just developed, we have a video on our website that was developed specifically to kind of combat some of those myths. So we did it specifically with our providers because we had seen some research that showed that people were more likely to listen to their healthcare providers about recommendations with the vaccine. So we had several of our providers across all levels just have some, dispelling those myths from, childhood vaccine, COVID vaccines to Native Americans to Black populations. And so we use that as a channel and just a very informative message for our patients. But, a lot of it was the same thing. We don't know what's in it. It's the microchip thing. We just tried to provide, evidence-based information. We got a lot of stuff from IHS, from the CDC that we use, that we, will either rebrand or just reshare a lot. So just continually trying to provide the researched information to people and just redirect as much as possible.
Yep, just to add on to that, that's exactly, within the Indian Health Service, we have tried to be very standardized with making sure that we follow CDC guidance. And that guidance that the IHS and CDC provides, we make sure that we have weekly calls with all of our tribal programs as well, making sure that that information is updated weekly. And then we try to use thought leaders in the community, whether that is our Native American churches, whether that is our veterans or our elders or whomever is trusted in the community, where we try to make sure that information is provided to them so they can counteract the misinformation. Because in reality, the IHS understands that it cannot handle a misinformation campaign from its level, that the misinformation campaign really needs to be done locally there where those partnerships and relationships trusted are already formed. We don't need to be showing up at the doorstep with a bunch of CDC information, because at the end of the day, it's just not a trusted environment. Those relationships take time. So we have tried to focus our misinformation campaign on tribal leaders, on urban leaders within our federal CEO programs, making sure they have the information to go out and combat the misinformation, and also having our community members help us at the end of the day. Thank you.
Great. Well, thank you both so much for your wonderful presentations and taking the time to talk with us through some of these questions. On behalf of our COVET membership, we're very grateful for your time and your contribution today. So thank you. We are in the final 11 minutes or so of our agenda, and I'm going to hand it to our colleague Martha Gabehart to share about a resource that is pretty powerful. And so Martha, I will get the video ready to share, but if you want to tee this up for us very briefly, that would be wonderful. We can't hear you. I think.
There we go. There we go. Sorry about that. Last week, I had an opportunity to watch the launch of a series of public service announcements that were put together by InterHab, Kansas Council on Developmental Disabilities, and the Sunflower Health Plan. InterHab is a professional organization of community developmental disability organizations that work with people with intellectual and developmental disabilities, providing services in their homes in the community. People with intellectual and developmental disabilities jumped at the chance at getting vaccinations, but they found their direct care workers didn't. And so they felt like they were being put at risk. And that several things were tried apparently to get the direct care workers to get vaccinated, but in the end, it was decided to try a social media campaign. And there are 5 videos, but we're just going to see one today. So if you want to go ahead and hit play.
Thanks.
It's really inspiring to see them just go do it.
I get a shot so I won't get the COVID.
I've been vaccinated.
It's just like getting the flu shot. We do it every season, so why wouldn't we do this to protect others?
Some people and the population of people you take care of might not have a normal immune response. So people that do not mount a normal immune response to the vaccination are more likely to have what we call a breakthrough infection, that is an infection after having been vaccinated.
The vaccine shots helps us to save our lives.
Immunity wanes. In other words, after the full vaccination, at the peak of immunity, for those people that have the ability to mount a good response, it does gradually taper off over time. And that's why you're hearing lots of talk about booster dosing for people that have been fully vaccinated.
They didn't got the vaccine.
It's impressive because they're just like, let's get this done and over with. And there's still so many people on the fence that are hesitant about it.
Can you do it for me, please?
Oh, you'd be staying here with me.
There's nothing we'll be afraid of. I got it. You can too. Get the shot and get protected for your family and yourself.
Pretty powerful there. Thank you.
Beautiful.
And you're welcome to everybody who said thank you in the chat about providing this. It's going to be pushed out mostly to social media, but there will be some of the folks who maybe will put that out on television as well. So good job to them. Thank you, Dr. Garcia and Vicki, for letting me share that.
Thank you for being here. It's very powerful.
Yes, very powerful resource. The website is on our slides, so we hope you'll take advantage of it. And thank you, Martha, for sharing. I know that we're very anxious to hear about the PAVE grants, so I am going to move really quickly just with a follow-up item from the last meeting. At the last meeting, we had a hearty discussion with all of you regarding sort of the key takeaways and things that we've distilled from the COVET work and how to make sure that we had a complete set of information, as well as how to amplify that and consider where we go next. So we reported the notes in our distribution of notes, but wanted to follow up just with sort of a pulling together of that. So I'm going to take just 1 minute to kind of show that as we go through. You might recall we were led by 3 questions. What are the implications and insights that should be raised up? How should we distribute them? And what is next for COVID? So in general, I think that the implications we had distilled, people felt were right on. And there was encouragement to just include that we needed to make sure that we elevate engagement and collaboration, that we engage in one-on-one conversations, and that we continue with an effort to communicate accurate information. And I think several groups noted that this is a long haul effort, that this is something that we're not going to fix or achieve overnight, and that we need to be focused on the long game. The second question was, how do we best distribute these implications and insights? And I think my summary of the notes sort of say any way possible, but I think that the use of diverse methods, much like the communications that we've talked about that are direct for vaccine, that we need to have diverse methods that get to diverse people. But also, I think the second bullet is really important. We need to consider how we engage you all in distributing this information and serving as champions for getting this information out. And then in addition, I think there were messages around making sure that we have clear information that's distributed through many different means. And then also trying to leverage, sort of at the bottom of the slide here, trying to leverage those people who have direct contact with communities that can support dissemination. And there were a few examples that were raised up, including some vaccine ambassador work, as well as local work using a model from Immunize Kansas Coalition and K-State. And lastly, we asked the question, sort of where should COVET focus next? And I will say that we used this information to plan this meeting. It was very evident that taking some time to learn more about the context for Native American and American Indian populations was important to the group. So we're grateful for that suggestion, and really enjoyed learning about that today. I think a couple other sort of potential topics down the road might include things like, how do we stop singing to the choir? I think this has been a theme for the COVET, that we've been able to get those early adopters, and how do we get the movable middle and the lagging populations here? I think there was hope that COVET would continue to highlight the out-of-the-box thinking and strategies that have been employed, and then consider sort of what post-COVID work looks like to advance equity. So again, we're really grateful for the thinking last month, and are pleased to sort of close the loop on this, but I think we'll be bringing some of these questions back as we move forward. And with that, I'll hand it to Dr. Garcia to close by talking about the PAVE grants.
Thank you, Vicki, and thank you to our presenters. What really struck me was leveraging relationships that you've taken the time to create, and I think that's something maybe we really need to, that we haven't been the greatest at in general. So before we wrap up, I just want to spend the next few minutes sharing information about a new grant program called the PAVE. You can put the next slide. Next slide. And it stands for Pandemic Assistance and Vaccine Equity Grant Program, or PAVE for short. So we're very committed at the state to supporting local groups who want to work to support vaccination in their communities. PAVE grants can provide up to $10,000, and a variety of groups and organizations can apply. Next slide, please. Examples of organizations that can apply: clinics, colleges, community groups, faith-based organizations, tribes, nonprofits. The funds can be used to support immunizations in a variety of ways. One big note is that they cannot be used for incentives of any type, but that's kind of like the big one that's out. But otherwise, they're semi-flexible. Next slide. So some examples of uses for the funds are educational campaigns, media buys, supplies to help support vaccination events, transportation for patients that need it to get there, personnel that you might need to help in your work, and also materials, printing, and so forth. So I will share the link so that if anyone is interested in this type of a grant, they can apply. Next slide, please. Next slide. I guess you could turn off the slides if it's easy. So we've come to the end of our time. Thank you all again for spending this hour with us. We are going to be sending out the notes, as we always do, as well as the newsletter, which will come in 2 weeks. Don't forget to share your work with us, because we love sending it out in the newsletter and highlighting it so other people can see what you're doing. Our next meeting is going to be October 20th. And look at that, we're done 1 minute early. So thank you, everybody.